Dr. Stanley is she's the director of nursing. And for those of you from California, from St. Mary's College in California, she's going to be talking to us, continuing this song on professional role clarity and identity formation in nursing education, where the rubber meets the road. But I want you to say thank you to her institution, to St. Mary's, or you wouldn't be getting continuing education. So thank you. Take it away.
Perfect. Before I start the presentation, I feel like I need to tell you how I got here. So I came out of nursing school in the 80s. So as you've kind of heard, the 90s was a very interesting time when the suits moved in. I went into management in the 90s, so I had a front and center position. In the early 2000s, I transferred over to a county facility in a staff development role and then in management. And I was confused about so much in nursing. I was confused with the quality events I was involved in. I was confused with the patient complaints. I was confused why my new nurses that we were precepting didn't understand nursing. I was confused about the bullying. I didn't get any of it. And then Dr. O'Rourke was hired in to help us transform the organization. And that event was actually life transforming for me. I went back to school and got my master's degree. And then I went back and got my doctoral degree. I am an accidental academic. So you say, how do you become accidental? Well, I am going to graduate with my doctoral degree, and I had decided I needed my honor cord for my master's program because I also got a business degree at the same time. I wanted that honor cord. And, poor planner, last minute, drive up, they had it for me. The dean comes running down the hall and says, you need to come teach for us. Okay. So that's kind of how I ended up in academia. I'm going to hopefully get to press this correctly. So what I'm going to do today is I'm going to talk about kind of the past successes I had with, I hit it twice? No, okay. Past successes, I had it with Dr. O'Rourke in a previous nursing program that we were just about ready to publish findings, but we went bankrupt, unrelated to nursing. Unrelated to us, but it did close our department. And then I'm going to talk to you about the new program that we're starting from the ground up and why I'm choosing to build Maria O'Rourke's work more thoughtfully in the program. So the history is I came and I joined this school to help them teach out this LVN to RN program. So the pass rates in this program were 40%. That was a pretty bad program. So I came there, helped them teach out. We had a horrible, horrible reputation. Clinical partners were getting ready to cancel our contracts. The hospitals just weren't happy. And then, of course, our school decided we're going to voluntarily close out this program. And the board gave us permission to open up a new program, which I'm still baffled to the day how that happened. And it was going to be an RN BSN traditional program. And basically all the curriculum was going to redesign. And at this point, I was teaching in the master's program because we were shutting this. We were teaching out we'd already taught out the last 6 students. I was done. Well, they couldn't find anyone to write the curriculum for the program. So I became the voluntold person to do it. Well, here's the other thing. I had no clue what I was doing. I had no clue how to build curriculum. I had no clue how to build a class because I'd been given everything, let alone a program. But okay, I'm in for this. Why not? Another tool for the belt. So the next thing is someone says, well, you need to pick out a theory. We have to include that. The BRN wants a theory. Well, most people, they had worked in academic, would have pulled out something like Orem. But remember, I'm still service-oriented. So, okay, we're going to use Dr. O'Rourke's theory. No one even knew what it was, but they were just glad I was building the program. So I already knew we had a gap in nursing. We had a gap from the students going over here in education and coming to service. I still work in service. I still moonlight as a house supervisor. So I really get there's a disconnect. So to me, it was like, all right, let's try this out. couldn't be worse than 40%. The bar was pretty low. So she came, I went ahead and I did a great job. I incorporated it in one class. I talked about professionalism, what it meant to be, owning your role. And the surprising thing was we started getting calls from our clinical partners. Your students are different. We want to hire them when they graduate. I'm like, well, that's intriguing. The clinical contracts weren't canceled. The BRN and CCNE then came for double accreditation. We were one of the first hospitals that, or first, excuse me, see, I still work in hospitals. We were one of the first academic institutions that got double accreditation where both accreditors came at the same time. And our Board of Registered Nursing only notified us 90 days before that they had decided they were going to come with CCNE. So, okay, that's interesting. What was more surprising was when they talked to my students. The BRN asked the students about their Nurse Practice Act. My students took them to the website. My students were showing, I said, I did not coach them. They said, we've never seen this. My students understood their role. During the pandemic, one of my instructors actually got ill. She had COVID, so she's quarantined the whole bit. So I took over her clinical. And I go there and I'm like, the nurses want to know when these students are graduating because they want to hire them. It's like their second semester, first semester in the hospital. And I'm like, okay. So then I got to watch. And it wasn't that they knew how to put a Foley in any different. I could train a monkey how to do that. They knew how to say things differently. They knew their role and they knew how to articulate to it. So when the nurses would say, oh, do you want to watch this procedure? Or if you want to do this procedure, they could articulate like, I would love to actually be able to help you this procedure, but I've never trained it. And I don't have the skills yet. I'm willing to be taught that before I go into the patient room. Can we involve my instructor? So the language and conversations were different. That was what the nurses were judging our students on, was how they could articulate, not the Foley. So my students, because they were communicating in their role, were actually getting more opportunities than a lot of students do, because the staff trusted that the students were going to say, I'm not comfortable doing this. I can't do this. I need my faculty to be here with me. It was very intriguing to watch. So let me go forward. So one of the hard things, though, that I discovered pretty quickly is I was the only one that could teach that class. That was what lesson. I put someone else in to teach the class, and the first thing she said is, why are we teaching in the ANA standards? What is this section 2725? So then I realized, no, our faculty come to us really competent in understanding their roles, so that was an eye-opener. And also, faculty don't necessarily know how to teach. So that transfer of knowledge that we're counting on in the academic setting, that wasn't necessarily happening either. The professional role concepts were not hardwired enough throughout the program. That being said, the outcomes were amazing. We had 100% pass rate the first 2 years. We had all our students were hired. The majority of students, there's someone in my faculty team that's still in contact. They're still working as nurses. Because one of the things they learned was exactly, if I don't like where I'm at, that doesn't mean I don't like nursing. I need to find a new place to work. That was another accidental finding. So I had an opportunity to go to work at St. Mary's, starting a brand new program. This was like a gift from heaven. The other thing, 100% of my faculty that worked with me at the last institution have followed me. I've also gathered additional people. I have so many people waiting for us to open that want to work. I hate to put it out there. I don't think we have a faculty supply issue. I think, which is a nice place to be in. And my whole evaluation for my career is the fact everyone wanted to come work with us. So what we decided is we wanted to really get Maria, Dr. O'Rourke, involved. And I gave her a call when I was interviewing for the job and said, so let me tell you what I did at my last place and what the outcomes were. So I want to do it more thoughtful this time. I want to research it, and I really want to understand how we can impact that bridge between the academic world and the service side. So when the students are coming in, They're not competent, by the way. They're practice ready and practice safe, because there still is a growth that happens on the service side. So we're looking to really get grounded graduates. We want them to be able to do that communication, that transfer of knowledge, critical thinking, but it's all based on professional role clarity. That is the first step. If they don't understand that professional role, they can't do anything else. It has to be embedded in simulations. It has to be embedded in your skill setting. And that's the other thing. We shouldn't do skills separately. There should always be a patient that is attached to that Foley catheter. There should be a condition. It should be based in reality, because the students get so focused on, if I can put in the catheter correctly without contaminating it, because it's a task, that what's the role? Why are you even putting it in the first place? What signs and symptoms are you watching for? What's the difference in an infection in a UTI with a 20-year-old versus an 80-year-old? All of those pieces become part of the role in teaching the students. So we looked at the fact that we really wanted to make sure that we had the complexity of the healthcare system. We're looking for clinical partners that actually use Dr. O'Rourke's work, so we're partnering up. We are also looking to be in a variety of interesting settings, and redoing our clinical model, which will be a whole nother lecture later. Not this conference. We're looking to make sure that patient advocacy is hardwired, that they understand that interprofessional practice, what that model looks like, and that they have that ethical practice. And it really starts with our orientation. So our orientation actually already talks about her work. It already is front and center what the expectations are. It's in all our policies, it's in our procedures, it's on our website, and we're currently getting all the faculty that are going to go live in the fall with our first cohort to really deeply understand this work. So even though they worked with me before, they all have to be able to sing the song. And that's a huge thing. When, part of my issue when I was so shocked is, I knew how to hum the song. I knew what professionalism was, but I couldn't articulate what truly my role was. And once you know your role, it changes your life forever. So this is our model, which really what we did is we came up with 8 learning outcomes. But the biggest thing you'll notice in the center is the do no harm. In academia, we need faculty to understand you can't harm the student. And the students get bullied by faculty and whatnot. Now, we've actually expanded this a little bit, because faculty sometimes get bullied by students, which is intriguing, but it does happen. So the notion is, yes, do no harm to the patient. But in the process of educating our students, we need to make sure we do no harm to them. They need a safe environment to learn in. So that was the center. And then you'll notice the transfer of knowledge, the accountability, the empowerment, the critical thinking, advocacy, and clinical reasoning surrounds it. But the next circle is the role-driven practice. That is encompassing it. Now, I work at a college, this LaSallian, that really believes in global perspectives. We have colleges all over the world. I'm actually being sent to Rome in May. I know, feel sorry for me, to be for 2 weeks, because they're actually thinking they may want to do something bigger with this work. And so they said, let's send you so you can do some collaboration with some other nursing programs out there and then come back to us. But this is how we built our model, so that it was front in everyone's mind, that whole role-driven practice was a key. And again, I talked about the core principles of doing no harm. It is the center of everything we believe in. We have a professional practice committee, which is the same concept of what we had at the last institution. We changed the name to be more positive, but it's a place you bring students when, let's say, they are failing, to come up with a new plan to do an intervention. If they've done some horrible violation, it's a place where they come and kind of is a part of a shared governance in the fact that they have a voice there. We often assign a faculty member to them that helps advocate for them, so that there's someone else helping advocate and protect the student. And that goes back to the whole model of doing no harm. The ethical practice sometimes we lose in academia, it's more than just the ethical practice at the bedside. It's what's happening in the classroom as well. It's ensuring that the bullying in the class, these students have been so competitive to get to us. We have to stop that competitiveness in the class and try to convert them to being a team, to try to convert them to working together. You go out and then you have to try to help them navigate the bullying in the workforce. It's still there from the 80s, which I'm still kind of baffled about that one. So we're making sure that the role-driven practice is center. So then we focus really, everything we're doing in every class is focused around her model. It's the making sure the students understand that they are a leader, that they are the decision maker, that not making a decision means you just made a decision. And that decision could cost someone their life. So having them understand they can't just step back out of the role, making sure that they understand science is front and center. I think it's going to be challenging to teach because some of the sites we used to use regularly, like the CDC, they've had a little bit of playing with those sites. So I think this is going to be an interesting year. We want to make sure that the students understand the importance of transferring that knowledge, that you have to be able to transfer the knowledge to your classmates, to your faculty. You have to demonstrate it in the skills environment and simulation and at the bedside. And then making sure that that practitioner piece comes into play. Also having them understand all the different ways that they can practice. Now, while I'm focused on the student in my presentation, at the same time, I'm making sure the faculty understand their role in that role-driven practice as a faculty member. A lot of faculty are still focused on the patient-centered, which is great. We don't want to do any harm to our patients, but we also need to acknowledge we can't do harm to our students, and that our role is not being gatekeepers, but shepherds to help the students cross over. That's a huge shift to get faculty to stop thinking at times that I'm the one I'm making sure only no, how do you grow them? How do we become shepherds so we have a great workforce? Because at some point, I'm going to need someone at the bedside. Oops, I didn't. And then, of course, we want them to understand self-regulation. It's all theory-based practice, evidence-based practice, and the legal responsibilities. All of our classes, each instructor is charged to find core measures that actually tie to their class, including our farm class. And so every class has nurse-sensitive indicators in it, has core measures, it has the legal responsibilities tied to that curriculum. So instead of just teaching them about the lung and pneumonia, we tied it to the core measures, we tied it to the medications, we tied it to the professional role. So all of this curriculum is being designed around what, Joint Commission. It's front and center. So it's not this hidden piece that then they walk into the hospital and they're like, what are core measures? Why are we doing this? So that is really embedding the evidence-based practice a little bit different. When we looked at it, building a model, because I think models help faculty and students see the foundation of everything has to be the professional role identity, that clarity. It has to be there because otherwise you're building on top of Stan. We need to make sure that they have those role-driven decision-making model. And then once you've done all that, that interprofessional collaboration becomes much more natural because they already know what their role is. Then you can help them understand the other person's role. This is Maria O'Rourke's I should say it's the O'Rourke Professional Role Decision-Making Framework, which really expands the nursing process. And this is what we're embedding within our curriculum, using some of her license handoff tools to really have the student thinking more deeply when they're making those decisions. And then, of course, remember, I love this. You have the organizational structure for all the sites you're going to. So all the clinical experiences, you have the student coming in contact with whatever the organizational structure. At the same time, we have organizational structure in academia. The students need to have a clear understanding of what that is. Professional satisfaction, the importance, once they understand their role, we're launching a shared governance model. Satisfaction of my students, we had very high scores even though our program, people finally realized, was closing at our last institution, because they actually understood their role. They understood the decisions that were being made. They understood why, no, you can't show up to clinical 20 minutes late and expect the instructor to let you in. They actually got that. Team efficiency improves because when everyone understands their role in a team dynamic in a group, I've heard horror stories about people with group projects and nursing programs. We didn't have those. And I think it was because in the very first semester, they spent so much time understanding what their professional role was, even as a nursing student, in the learning process and supporting each other. When we had students struggling, one of the things, we said is it's everyone's responsibility that that student succeeds. So sometimes the person to mentor and teach them on the lung may not even be the faculty member. So getting everyone to take responsibility as that team approach. Ultimately, once you've done all that, patient safety just comes in it. If you have nursing students that come in and they're practice safe, practice ready, not competent, they know when to say, I don't know how to do it. They know when to ask questions. They understand their professional role. Give me someone that needs to learn how to put a Foley in. I don't care if they know how to do their role. The task is easy. So that's the kind of the flip in thinking. Once you put that on the bottom, the next thing we use is the CUSIN model. And the reason I like the CUSIN models is really for one key piece. It's the KSAs. When faculty come to me and say a student has a problem, is it a knowledge, a skill, or behavior? If we've done a good job at getting the students to understand their professional role, we should have very few behavior issues. If you do, there's still going to be the occasional student that may have to leave because they should not be practicing. The reality is most issues are knowledge or skills. When the faculty starts to look at it different, they have two different solutions. Don't send someone to the simulation lab that doesn't have the knowledge because it's a moot point. So we use the CUSIN in order to really focus on that. Next, you have the AACN, BSN Essentials, which we're tying everything to. Once you've done those three elements, you already have the NCLEX blueprint. It's already there because all those pieces feed up into it. You may have to focus a little bit on where you're doing your crutch walking, those little components, but the reality, it's all built. And then when nurses know and own their professional role, they lead from it, elevating the profession. So we are going to set this up as a research study. We are also creating a kind of a new, not pedagogy, it's an advocacy, I can't say the word, for the program. And we are going to look at getting IRB approval. And part of the new model is incorporating 3 different theories. It's an adult learning theory, it is a transformative model for education, and then Dr. O'Rourke's work. And we're doing it in every class versus one class. So all our classes are tied from the very beginning to what is your professional role, what is your clarity, and that includes our pharmacology and our pathophysiology. And that's it. Questions? This is the learning environment. Question, thought process, start singing. We have a question down here.
I think it's more of a comment than a question. So I am a master's prepared RN. I work in, I wouldn't say a hospital, but I work in a large health system. And we write simplified guidance for our physicians and APPs to make evidence-based practice easier to access and reduce variation. So in doing that work, I also didn't want to lose my skills. So I went back to just do some PRN work in the hospital. I feel like I have a really good understanding from a leadership perspective and operations and all of that. But one thing that I felt when I was doing those PRN Saturdays is that everything that you're saying and that was shared earlier is great, but I can know my role and I can go in with all that understanding, but there is no time. There is no time, and I easily lost inspiration to want to deliver that care because I'm exhausted and I have 150 things thrown at me that kind of takes that, what you're saying, and the application away because there's no time. And so my wheels are turning, but I also just feel like at that aspect as a new nurse, if I were a new nurse, I've been a nurse almost 20 years, or if I wanted to do something, how do I not add to the layer of complexity on top of regulation? Because I can't just keep hopping jobs if I'm not in a leadership role. But I feel like everywhere you go, it is a lot of that.
So I think when you're looking at the professional role as a
No, I'm
separate
throwing a lot.
element,
I'm like,
yeah, when you look at it as a separate element, you're adding. We don't add it to the pieces. Everything they're learning is in context. So your professional role when you're implementing at the workplace, I still work as a house supervisor, and I have some interesting shifts where I'm direct care and this and that. It's understanding, when to speak up. It's understanding how to speak up. It's understanding
Presentation, but they're
what
about
you shouldn't do.
they
I
want
had some
everyone
nurses
to.
who were into a procedure that was against our nursing act.
Mm.
So knowing your professional role is also keeping you out of prison. So what we're doing is teaching it at the foundational level. So the students that we graduated from the last place, 90% of them, one of us still has contact with. They're still working as nurses, maybe not at their first job. We have a nurse that I mentored. She was like, "Yeah, the hospital isn't for me." She's actually is a school nurse now.
Mm.
So I think getting to the right
Just
place
funding,
where you
really.
can
Just making
practice.
sure I get
I
enough. I
also
have
know
enough
there's a
funding
couple
just to
hospitals in
support
the Bay
myself.
Area I
That's
won't
it.
mention
But
that
everything is
when my
like I
students
have to
went there, they
take
all
everything
left
one step at a
because the
time. So that's
practice
why I'm like
environment was
managing my
hostile.
anxiety because I
So
just
I
like
am
I'm like I'll be
producing
like
nurses
too
that the
like
reality is those
I'll put
hostile
too much on my
environments,
plate and then I
they're
get
going
all
to leave
anxious and
because they
whatnot. So just
can't
doing things like
practice to
one
the
at a
role.
time.
So
Yeah.
even though we have all of these
Yeah.
crazy elements, and I'm proud to say that the two places I work at, I can, because I have two per diem
Yeah.
places that I moonlight in. I can practice to my role. I can hold the line. I can speak up and say, I'm calling the CEO because the physician on wants to do something very crazy and probably illegal, if not immoral. So I can use my role in my settings. And I would tell my students, if you get to a setting where you can't use this professional role, which is the foundation of what you show up, you need to leave.
So you're saying that foundation is taught early so that you have less
Yes.
confusion and
Yes.
feeling overwhelmed when
Yeah.
you go into
Yeah.
wherever your setting is.
And it's so foundational that that's why the students, when they were asked if they understood what their practice act was, took them to the practice act because they understood dependent and independent functions. It wasn't an extra role for them to think of it. It was so ingrained from just the one class that it had become part of who they were. And that's what the nurses were seeing from the students. So since I was able to be that successful, accidentally, because remember, I didn't know what I was doing, and have that type of impact, how much better is it going to be that every class incorporates it? Yes.
So the question becomes, so you prepare them in the school, right? And we put them in hospitals as new nurses. But what if the pressure is not from the CEO or the organization? It's from nurses who have been working in the profession and they're burnout and they're the ones that's doing the bullying. How do they manage that?
The bullying piece is something I'll admit, we still have to navigate that. One of the things that I will say the professional role piece helped the students do was recognize it wasn't them. And sometimes when you're being like, has anyone ever like flipped you off in the car? And you're like, I didn't even do anything. So you don't really pay it any mind. So while bullying in the workplace is detrimental, I think the fact that the students were grounded in what their role was and how people should behave, they kind of, it wasn't the same impact that I saw at another university that I worked for a year. So I can't tell you for sure. This is just like a feeling that it kind of insulated them a little bit, and recognizing you had the bad behavior. I don't have to take it home with me. But I will say there were 2 hospitals in the facility. Anytime in the Bay Area, anytime students took jobs there, they left within 6 months and they went somewhere else. So there is that element of that toxic environment. And I think someone needs to, not me, someone needs to come up with a solution of what do we do with the bullying in the workplace, because it's alive and well and thriving. There you go. Yeah. I'm not the bully expert at all.
Hi, so just on the piggybacking from that, what we've done is we've really done a lot of work around professional communication with our nurses, new and existing, how to give feedback, how to take feedback. Because when you are in those bullying situations, or when you are in your workday and somebody's negativity is just bringing you down, you have to feel empowered to speak up, because otherwise you're just going to go from job to job to job. You have to find a way to say to that person, hey, what's going on? Is everything okay? Because you're really negative today. It's okay to say that. And what we do is we offer, they'll come into us, we'll mirror some conversations, we'll role play. Okay, well, what if that person says this? What if they get really snarky? And it has made a huge difference on our unit.
I think that the challenge is when you have hospitals that are willing to collaborate, and keep in mind, what I'm doing is like a dream. I'm building the culture, not changing a culture. That is much easier, just for the record. So even the last time when I built a brand new program, I built the culture, I didn't change it. So acknowledging that piece. But when you do teach students the role, their communication out on the floor was so different. The nurses during the pandemic thought this group was ready to graduate. So second semester students were communicating as if they were graduating and not prepared. So that communication itself probably prevents some of the bullying from occurring that I saw at another institution that I worked for a year, where it was nonstop. I was like having people in my office in tears. We just didn't have that. And I think it was, again, by accident, the fact that everything was based from day one about the professional role, about transfer of knowledge, about speaking up. I mean, the whole series on speaking up, on advocating, moving those difficult conversations. We did a lot of role model, a lot of immersion. We would show videos of poor behavior and then have them take it apart and figure out how they could demonstrate a better way to handle a reaction. So we got very innovative with how to teach the professional role with a lot of different media. And again, accidentally, those were the outcomes. And now I want to be more thoughtful. And so that's why Dr. Maria Work is come to work with St. Mary's, so that we can really hardwire this in a more thoughtful way and actually say, what are the outcomes? What was the student's experience related to bullying? What was this? So that we actually can publish to what has worked or not worked. So that's kind of the goal. And it was totally an accidental findings that we had.
I don't need a mic, but my name is Tuesday. I just want to thank what you're doing. It's really, really great. I've been in leadership now over 10 years, and we've brought on a lot of nurses, and I feel like from a management perspective, I'm now a chief nursing officer of long-term acute care facilities. But I've been a director, I've been a nurse manager for many years, and I feel that was a lot of what I was doing with the new staff. So I really hope and wish you great success in this. I think that this is going to be extremely pivotal for those of us that are younger in our profession and spend a lot of time with this. So I think what you're doing is really, really great, and I hope to see it in a lot of nursing schools across the country. So thank you.
I paid her.
She did not.
I don't have a question so much as a connection. I think that what I see in a leadership role for my nurses is this kind of have given up their power. And then this lack of role clarity, which then plays into an inability to have conversations or embrace the profession of nursing. And they want to stay focused on the task of nursing. And so I'm hopeful that we can piggyback on academic changes to leadership changes within nursing environments to kind of squish that gap that exists. I mean, so hopeful to see new nurses come out, like you said, like new nurses that have these skill sets, but there's going to be a pretty big gap there in the current workforce to wait for this new wave, which is going to take a long time to trickle, right? So if we can attach it to our leadership styles, our work sessions, our conversations, our one-on-ones, our connections, we have a much better opportunity than waiting for that kind of the academic wave to hit. Yeah, absolutely.
Agree.
Thank you.
Let you know that recently in Nursing Outlook, I found a paper with one of our clinical partners, USC Verdugo Hills is one of our clinical partners. We've brokered a relationship with them and they use my work. And we just published, for those of you who are talking about workplace violence, we just published an article in Nursing Outlook this last month. And it's right now, it's free. It's on open access. And it really talks about how theory helps us understand workplace violence, and using my framework to explain why the chief nurse, who is one of the members of one of the article authors, and the professional development specialist were able to craft a program within their institution to address this issue. And it just got published, so please do that. And the other thing I would say is, if you walk away and understand the difference between owning your professional role and living it, the scope of practice is not a thing to do. You are the scope of practice. If you're not living it, then it's extra. It's not extra. It is. It's your way of being. And what we have to do is make sure that the way we know we can be professional nurses, we have to clean up the work environment. One of the things that happens in the work environment is the first thing you get when you go to the job, because it's a job where you're going to do the work of nursing. Okay? The job is not nursing. The job is the place in which you do the work of nursing. And if you don't understand the work of nursing, then you will become task-oriented, because the job description is task-oriented. So if I read the job description the day I get there, I go, okay, well, I guess that's what I'm supposed to do. Sorry, Pam, but that's what I have to do. The answer is no. The job description needs to be transformed so that it is a role description, not a job description. And so think of it in terms of, you go someplace and this is the way you are. This is the way you work. This is the way you are, a way of being. And now you're in a place that says, whoa, we don't like that. Well, right from the beginning, you got an uphill battle. And when it starts to change your life, the answer is, yeah, you can't be there. Management has to get the furniture out of the way. That's what you're there for. And we can't have a clinical enterprise if we stumble as clinicians every single day and we don't have time to do the good work that we're supposed to be hired to do in the first place. So keep those two separate. It took a while to get ugly environments, and unfortunately, there aren't enough magnet hospitals to push it to the, fast enough. So for those of you in management, we need you. We need you to clear the furniture. We need you to understand the principles of professionalism, and we need you to support the clinicians who are, in fact, attempting to be a professional registered nurse.
And one of the things we did, just to add, we're taking our students down week 5 and 9. We've made those hybrid weeks for the students. And so groups of students will take turns going down to Verdugo. It's 6 hours away. We'll be housing them for 5 days. We don't pay for the transportation and the food, but we do house them. And part of that partnership was so that we really could understand. They have a transition to practice program based around the model. The staff have been trained in the model. You have their leadership implementing, all of this, and then to have students come in is to really understand what is those different experiences. How are those evaluations going to look for the students? So we were very thoughtful in wanting to see that connection with an environment that had thoroughly embedded this work.